Hello everyone, this is Dr. Muhammad Asad. I am resident in radiation oncology and today I will discuss CDK4/6 inhibitors, Palbociclib, Ribociclib and Abemaciclib. CDK, as the name indicates, cyclin dependent kinases. So let's discuss what are kinases. Kinases are the enzymes that bring about the changes of adding a phosphate group to a protein or a molecule. And what are cyclins? Cyclins are the proteins which regulate the cell cycle. So as you can see, these are cyclin D, cyclin E, cyclin A and cyclin B/A. They are named because of their cyclical expressions. So these kinases are cyclin dependent, that's why they are called cyclin dependent kinases. So there are multiple CDK1, 2, 4, 5, 6, 7 and 9. So let's discuss what is cell cycle. So cell cycle consists of 16 hours, and among 16 hours only 1 hour is taken for mitosis. So it starts from G1, S phase, G2 phase and M phase. So the transition of one stage to the next stage is regulated by a set of proteins called cyclins and their associated cyclin dependent kinases. When this complex is made, this brings about changes of phosphorylation of a target proteins, that is retinoblastoma protein, RB protein, which partially activates E2F factor and cyclin E and CDK2 complex, which further fully activates after hyperphosphorylation of RB protein, and this will bring about change of uh, cell cycle proceeding from G1 to S phase. So this figure is taken from molecular biology of cancer. So what really happens in cancer? So in cancers, uh, there is upstream activation of mitogenic pathways like the growth factors and the mitogenic pathways that will increase the activity of CDK4/6 and increase expression of cyclin D and E, results in hyperphosphorylation of RB protein, and that will bring about changes of cell going from G1 to S phase, and there will be no cell cycle arrest. So this is the main mechanism of cancerous cells by going unregulated growth. So what does CDK4/6 inhibitors do? They they block that CDK4/6 complex, and that will result in hypophosphorylation of RB protein in the sensitive cells definitely, and that will result in cell cycle arrest. From the cells will not go from G1 to S phase. So let's talk about the background of CDK4/6 inhibitors. So initially the pan CDK inhibitor was flavipiridol. So interestingly, this compound was also isolated from a plant from India that was believed to have medicinal properties. So this causes cell arrest at G1 and S as well as G2 and M phases. So this was the first generation pan CDK inhibitor. Then came Salicylib that inhibited CDK2, 7 and 9. Then came Dinaciclib that inhibited CDK1, 2, 5 and 9. And now we are talking about third generation of CDK4/6 inhibitors, that are Ribociclib, Palbociclib and Abemaciclib. So let's discuss the mechanism of CDK4/6 inhibitors. The inhibitors of cyclin CDK complex 4 and 6, and this will blocks G1 to S phase of cell cycle, ultimately resulting in decreased phosphorylation of Rb protein and resulting in decreased E to F expression and ultimately causing cell cycle arrest. Regarding the resistance of CDK4/6 inhibitors, there is increased expression of CDK6, CDK2 and CDK4, loss of phosphorylated Rb expression, overexpressions of cyclin A and E, and increased expression of 3-phosphoinositide dependent protein kinase 1 with activation of AKT pathway and other AGC kinases. These are metabolized in liver, and the drugs that stimulate liver CYP3A4, they will increase metabolism, ultimately lowering the drug levels and resulting in decreased activity of CDK4/6 inhibitors. While the drugs that inhibit liver CYP3A4, that will reduce the metabolism, ultimately increase the drug levels and increase its activity. The bioavailability of CDK4/6 inhibitors is 46%. So when we give CDK4/6 inhibitor to patient, we monitor CBC for neutropenia, for low platelet counts, and for looking of anemia. Initially every 2 weekly for the first 2 months, then monthly, and as well as LFTs as the metabolism is in liver and there is derangement of liver enzyme AST and ALT. And we also do baseline ECG if we are giving ribociclib, because the toxicity of ribociclib is that it will prolong QT interval. And regarding doses of these three CDK4/6 inhibitors, Palbociclib is given as 125 mg per oral OD for 21 days followed by 7 days off, and Ribo is given 600 mg per oral OD for 21 days followed by 7 days off, while Abemaciclib is given 150 mg per oral BD with AIs and 2 mg per oral BID as monotherapy, and these all are given with along with AIs. Regarding half-life, elimination half-life of Valbo is 26 hours, Ribo is 32 hours, and Abemaciclib is 18.3 hours. Regarding indications, CDK4/6 inhibitors are indicated in hormone receptor positive, HER2 negative metastatic breast cancer, and these are as indicated as first line along with AIs. And these CDK4/6 inhibitors revealed PFS benefit, while ribociclib revealed OS benefit as well. These were the trials. Paloma 2 investigated palbociclib, and Mona Lisa 2, Mona Lisa 7 investigated ribociclib, and Mona Lisa 2 also showed OS benefit, and Monarch 3 investigated Abemaciclib. And one thing is that all CDK4/6 inhibitors have been evaluated after disease progression on the endocrine therapy. The addition of CDK4/6 inhibitors to fulvestrant improved progression-free survival and overall survival compared with fulvestrant alone. Regarding the adjuvant indication of CDK4/6 inhibitors, these two trials, Monarch E trial investigated Abemaciclib, and it yielded 3.5% increase in invasive DFS at 2 years, and the indication were hormone receptor positive and HER2 negative high risk CA breast patients. High risk features included 4 or more positive lymph nodes, 1 to 3 positive lymph nodes with tumor size of 5 cm or larger, or grade 3 histology. Natalie trial evaluated ribociclib plus AI in adjuvant setting in node positive and high risk node negative hormone receptor positive HER2 negative breast cancers, and it yielded 3-year invasive DFS of 90.4% versus 87.1%. The two trials, Pallas and Penelope B, investigated Palbociclib as adjuvantly, but these both trial failed to meet primary endpoint of DFS. So regarding toxicity of CDK4/6 inhibitors with suppression with neutropenia, and neutropenia is seen more with palbociclib and ribociclib, but this neutropenia is not febrile, so it is very rare to have febrile neutropenia with CDK4/6 inhibitors, and this neutropenia is the more common reason for the dose reduction. Other is anemia and thrombocytopenia. Fatigue is more common. Upper respiratory tract infection are also common. Nausea, vomiting, abdominal pain, and diarrhea is frequent. While diarrhea more reported with abemaciclib, and there is increased risk of thromboembolic events like DVT and pulmonary embolism, and there is also hepatotoxicity and more with ribociclib, and there is no dose reduction required in mild or moderate hepatic or renal impairment, while it is not studied in severe hepatic or renal impairment. So alopecia is also seen with palbociclib, and one thing is very important, that QT prolongation is seen with ribociclib, and all CDK4/6 inhibitors should be taken in morning as sleep. There is natural bradycardia, so these are avoided in night time. So thank you so much, and questions are welcomed. Please do let me know if there is any question, and like, share, and subscribe to my channel Oncovedasar, and I usually post a lecture monthly or fortnightly on pharmacology or biostats, discussing trials as well as art indication in certain cancers. So thank you so much for supporting.